Yes, thank you for the invitation, even though coming from sunny Germany with 27 degrees and no clouds to... I was wondering whether this is a political consequence of the Germans being too strict on the Greek and saying you have to have the same weather as in Germany. So I'm sorry. It also prevented me from going to Delphi and asking the question that you asked me, because maybe Delphi can answer the question for this. Can we? Oh, the slides are on. Just, I want to start with something difficult, and let's see whether I can get the video started. This is. Can you put the noise off? This is autoimmune hepatitis and PBC. Can we have no noise? Very good. So it depends which way you look at it. It's looking at a mirror, and it comes with different consequences. And this is becomes more complicated if you look at it even more closely. So let's see whether we can solve that myth. Is it a reality or is it a myth? And I will start with the case again, with the 21-year-old male patient who came to our hospital exactly 2 weeks ago. So it's very up to date. Reported jaundice, abdominal pain, malaise, fever, some respiratory symptoms, no medical history, no medication he had taken, no risk behavior. He was jaundiced, he had a big liver, otherwise it was unremarkable. So we did all the testing that George just told you about, including hepatitis E virus, of course. Patient had high transaminases, high alkaline phosphatase, jaundice, high IgG, he had been vaccinated, and fibroscan already showed a stiff liver, all viral tests are negative. And then in a young man, you get this result. In fact, it came back after the liver biopsy because I decided he should have a liver biopsy quickly. And the liver biopsy shows this. Clearly both PBC and hepatitis. Hepatitis activity score of 9 out of 18 and PBC stage 1. I have another comparison of different parts of the same biopsy. So here you have the interlobular hepatitis everywhere, and here you have the typical PBC lesions, but also interface hepatitis. So how do you classify this patient? I mean, clearly this patient has autoimmune liver disease, whatever you call it, whether you call it autoimmune hepatitis or PBC or both or overlap, he has autoimmune liver disease, even though he's a young man. So I can only give you 1 week follow-up because it was very up to date, but very nice response to steroids. In fact, while we were waiting for the biopsy, bilirubin went up even higher, so there was clearly a need to act. And then with steroids, he starts responding. So clearly he needs, at this stage, treatment for autoimmune hepatitis. But he does have PBC. So he has both. You also just learned about the new wonderful drug that treats PBC so effectively, obeticholic acid. And Olivier had a little 2 words on this slide saying it's also immunosuppressive. This is the slide he's referring to. It's a very effective immunosuppressive drug. This is an experimental study in mice with a model of encephalomyelitis, of multiple sclerosis, and showing that obeticholic acid can completely suppress the disease in these mice. So it's a very effective immunosuppressive drug. Here's a slide that you've just seen. Not just on alkaline phosphatase, even transaminases are suppressed by obeticholic acid. So maybe some of the very good effect that it has in PBC is its immunosuppressive effect. And the French group have shown previously that the survival is poor in the non-responders. And maybe some of these non-responders, maybe many of these non-responders are patients that have PBC and some degree of autoimmune hepatitis. This is a more normal result that you see in the biopsy, and I prefer to call it inflammatory PBC or PBC with secondary autoimmune hepatitis. Here the wonderful duct lesion, so clearly this is a destructive cholangitis, but also the interface hepatitis. So what is a patient that we would, in the past at least, call overlap autoimmune hepatitis and PBC? It should be a patient who fulfills diagnostic criteria of both autoimmune hepatitis and PBC. But as was discussed earlier this morning, what are the diagnostic criteria? And depending on which one you use, you get a different definitions. And the old criteria that we had for diagnosing autoimmune hepatitis had a strong bias against overlap. If you have any sign of cholestasis or AMA, you can't have autoimmune hepatitis by definition, but this doesn't change biology. So when you are asked the question that I'm being asked, the problem is also a problem of time point. Are you studying the patient at the very first manifestation of the autoimmune liver disease? But then you have patients who start off with autoimmune features, or you have patients that start off with PBC features. Do you look at them at the time when they at the first time show both? So you can start with autoimmune hepatitis and later on have PBC, as mentioned earlier. But you can start with PBC and later on have autoimmune hepatitis, or you can start with both, as this young man did. A young man. It's not what you expect in PBC, but it all happens. And if you look at all studies trying to define how many patients have an overlap, and you look at autoimmune hepatitis like Alchaya did, but he is a specialist in autoimmune hepatitis, then you see some patients with autoimmune hepatitis and PBC. And he sees very few PBC patients, lower numbers, and you have about this percentage of autoimmune hepatitis PBC patients, so he has a higher percentage because he is an autoimmune hepatitis person. Then, this famous author defined overlap if you have transaminases 5 times normal and IgG 2 times upper limit of normal, which is very high. It's very rigid. Clearly, if you have that, you have autoimmune hepatitis. And our young man had this. But there's a spectrum below that. If you take these very strict criteria, then he finds just 10% of his patients with PBC and autoimmune hepatitis. But clearly, if the criteria are less strict, and normally for diagnosing autoimmune hepatitis, the criteria are less strict, then you have a larger proportion of patients who have both diseases. Because if you look at just autoimmune hepatitis patients, less than 50% will fulfill these very strict criteria. So if you use these very strict criteria, you will miss patients who have important autoimmune hepatitis. But the question you are asking me is, a patient who has autoimmune hepatitis and PBC, does he have 2 diseases? Or is it a separate disease that has features of both of these? Or is it a continuous spectrum? And some patients have clear autoimmune hepatitis, some have PBC, and then there's some in between all the way. Or is there a subgroup with this kind of overlap? Now, if we ask, do patients with typical autoimmune hepatitis have or develop features of PBC? It happens, but it happens very rarely. Do patients with typical PBC have or develop features of autoimmune hepatitis? Yes, that happens quite frequently, somewhere between 10 and 20%. So that makes it look more like autoimmune hepatitis is kind of a complication of PBC or a specific subgroup of PBC rather than a continuous spectrum or separate diseases. And I like to refer to this very old study by now, but still one of the most cited ones. We looked at 20 overlap patients whom we called overlap for whatever reason, compared with 20 randomly selected autoimmune hepatitis and 20 PBC patients. Overlap patients either by clinical criteria or histopathological criteria selected, and we did the study together with Hans Dienes as pathologist. Typical features as you expected: alkaline phosphatase in autoimmune hepatitis rarely elevated, PBC always elevated. And overlap, interestingly though, it's in between. It's not that they have the same degree or even higher in PBC, because I also like the term aggressive PBC, but it doesn't quite fit, because you would expect if this overlap is an aggressive form of PBC, they should have more alkaline phosphatase. And similarly in ALT values, are not quite as high as in genuine autoimmune hepatitis, but almost. So we looked at different features. How do they behave? How do these patients behave? What is the age at diagnosis? Now, the overlap patients had the same age at diagnosis as the PBC patients. They were 10 years older than the average autoimmune hepatitis patient. Not a significant difference, but it's a hint. Sex ratio, also just a hint. Almost exclusively females, very few males, while in autoimmune hepatitis it's 1/4 males. Histological features of bile duct lesions. In true autoimmune hepatitis, you can sometimes have mild bile duct lesions, but you never have severe bile duct lesions, while both in the genuine PBC, of course, but also in the overlap, all the patients have significant bile duct lesions. And then we went back to an even older idea that autoimmune hepatitis is strongly influenced by the genetic predisposition, and that can be measured by the HLA type, which now has a more complicated naming, but it's still the same tissue antigens, and found that the overlap patients had the same genetic background as the autoimmune hepatitis patients. And from that, we formulated the hypothesis that it's particularly, not exclusively, but particularly patients with PBC who have the genetic background of autoimmune hepatitis that then develop features of both diseases. And we believe, although we cannot prove it, that probably what happens is you start with PBC, which may be non-clinical. You may not notice it because the patient is asymptomatic, very little change. But of course there's inflammation at the bile duct, and that exposes the liver lobule also to cytokines. And if you then have the susceptibility gene for autoimmune hepatitis, you can then have antigen presentation in the liver and hepatitis as a sort of secondary phenomenon following PBC. So this, I still believe, is how it happens in the majority of patients, even though it's difficult to prove. The clinical consequence, however, is limited to this discussion. If they have autoimmune hepatitis features, they should be treated like autoimmune hepatitis because it's a serious disease. And I believe the same applies to autoimmune hepatitis and PSC, primary sclerosing cholangitis. Another example, an old example of a patient with clearly high transaminases and alkaline phosphatase, but also high IgG, typical features of primary sclerosing cholangitis on the cholangiogram, but also typical interface hepatitis. And on immunosuppressive therapy, everything normalizes except the alkaline phosphatase, because PSC does not respond 100% to immunosuppression. So overlapping presentations in PSC and autoimmune hepatitis, and we try to make a consensus paper in the autoimmune hepatitis group that Kirsten Boberg was the first author of. We said, well, we have the different groups. We have typical PSC with features of autoimmune hepatitis at diagnosis, but we also here have patients with typical PSC who have a sudden flare of autoimmune hepatitis. It's very rare, but it happens. Or typical autoimmune hepatitis not fully responding to immunosuppression and remain raised gamma GT and alkaline phosphatase, and the two diseases can, of course, be associated. This actually is the most common feature that you have in PSC autoimmune hepatitis: overlap or coincidence or inflammatory PSC. And it's probably the adult version of what Georgina Mirli-Vergani in children calls autoimmune sclerosing cholangitis. So there, I think it's a continuum. It is more common in children than it is in adults, but it happens in both age groups. And again, a similar study with the PBC study with autoimmune hepatitis patients, PSC patients, and overlap patients. Similar findings that transaminases are not as high in the overlap patients as they are in autoimmune hepatitis. Here, however, alkaline phosphatase is higher in the PSC autoimmune hepatitis overlap. So it would fit more in the idea that aggressive PSC or inflammatory PSC is what is this subgroup. They do respond to immunosuppression, more or less all patients, but not all of them normalize. Especially alkaline phosphatase does not normalize in all the patients. And survival is much poorer than it is in autoimmune hepatitis. If you treat autoimmune hepatitis well, patients have a normal life expectancy. However, it is more or less the same, or maybe a little bit better even, than normal survival in PSC. So PSC does not respond to immunosuppression. Patients who have aggressive PSC with autoimmune hepatitis, the autoimmune hepatitis responds, but the PSC sclerosis progresses. The consensus statement that we came up with is that, and this is sort of what is clinically relevant, if you have a patient with PBC or PSC, and that patient has high transaminases or high IgG levels, this patient should have a liver biopsy. Because the liver biopsy gives you the answer of how much hepatitis there is. It's not the enzymes. The enzyme suggests higher hepatitis, but the biopsy that gives it. And if the biopsy shows you features of autoimmune hepatitis in PBC or PSC, then you should probably add steroids and other immunosuppressive agents, azathioprine as a standard, in addition to also the oxycholic acid. But treatment needs to be individualized. There's no standard protocol because patients can be very different. Some can have very aggressive hepatitis, like the first patient that I showed you. Some only have mild hepatitis and only need very little immunosuppression, or only for a short period immunosuppression. So I would like to summarize the myth and fact discussion. I do believe this is a fact. You do have patients who have autoimmune hepatitis and PSC, or autoimmune hepatitis and PBC at the same time. It's just a question of terminology, what we call it, but it's these are related diseases. In PBC, I believe autoimmune hepatitis is secondary. In PSC, it may well be that's aggressive PSC, but whatever it is, the autoimmune hepatitis component needs immunosuppression. Like normal autoimmune hepatitis, also autoimmune hepatitis in PBC or PSC needs immunosuppression. Because the activity of PBC and of autoimmune hepatitis affects the prognosis of the patient. So if the patient with PBC or PSC has autoimmune hepatitis features, he has a poorer prognosis, and that seems to be improved by combined treatment of both diseases. And like in autoimmune hepatitis, you try to have the hepatitis component suppressed. You measure by normal transaminases or normal IgG, but the true test is a liver biopsy showing everything is normal. And I will finish with this video again and hopefully stop it in between, because it's in between. You see, it's neither a square nor a round. It's sort of in between, and it depends on which angle you look at it. So it has both features, like our patients, I believe, have both features. So thank you very much, and I think we will progress to discussion.